Hi, and welcome to Clinical Liver Disease video series. Clinical Liver Disease is an official digital learning publication of the AASLD. I'm Kim To, Assistant Professor of Digestive Disease at Yale University and Associate Editor of Social Media Section with Clinical Liver Disease. I am joined by Dr. Abbey Barnard from the Division of Gastro and Hepatology at the University of California, San Diego, to discuss her article, Non-Invasive Imaging is the Preferred Strategy for Cardiovascular Risk Stratification in this Patient. Thank you for joining us.
Thank you.
So we have a few questions. One is, why do you think it's important to risk stratify the cardiac risk factors for a pre-liver transplant patients?
So cardiovascular disease remains the leading cause of post-liver transplant mortality in the modern era. The demands of a large liver transplant surgery warrant a robust pre-transplant cardiac evaluation that can rule out significant coronary artery disease. The 2013 joint AASLD and AST practice guidelines recommend non-invasive testing as a screening mechanism with subsequent cardiac catheterization if coronary artery disease cannot be confidently excluded. So especially with the changing demographics and the aging pre-transplant population, it's an important charge to the transplant hepatologist to find a safe, efficient, and effective way to risk stratify prior to transplant.
So what are some of the drawbacks you see in these non-invasive cardiac assessments? Obviously, as some of our cardiologists would say, a catheterization will tell you for sure what you're dealing with, especially when the stakes are so high with transplant patients, right?
Yes, absolutely. And, depending on where you may be in terms of the culture of transplant hepatology and selection at your particular institution, you may be getting feedback from anesthesiology, from cardiology, trying to come to some type of consensus about what tools should we use. Now, historically, the dobutamine stress echocardiography has been routinely used to risk stratify low and intermediate risk individuals prior to transplant. However, there are important limitations of this modality, which often leads to patients going to a more invasive form of testing. Unfortunately, while dobutamine stress echocardiography is safe, widely available, it's only reliable if your patient is reaching 85% of their maximum heart rate. Now, as we know, and depending on your region, this may even be more true, we often have extremely sick and very debilitated patients that are undergoing transplant workup. The ability to reach the maximum target heart rate can be limited by beta blocking agents, peripheral vasodilation, and chronotropic incompetence. A recent systematic review highlighted that only 70% of patients undergoing DES as part of a liver transplant evaluation were actually able to achieve their goal heart rate, resulting in a significant proportion of inconclusive tests.
Wow, that's really interesting. And I do agree, in regions like Northeast and Southwest, we definitely have this issues of patients being so sick. What are the advantages of coronary computed tomography angiography as compared to traditional invasive cardiac catheterization for cardiac risk stratification prior to transplant?
Yes, so while CCTA is certainly a mouthful, it's also been a really big game changer in the diagnostic landscape of cardiology. So first off, a CCTA is extremely easy to obtain. You just need an appropriate scanner and access to have IV contrast administered. So very similar to a CT chest that we might obtain on a routine basis. And then this is just a very sensitive test. CCTA had a sensitivity of 99% and a negative predictive value of 97% in ruling out obstructive coronary artery disease in symptomatic patients. As such, when looking to it for a screening tool and when it's been analyzed in the liver transplant population, it's essentially been found to have a negative predictive value of 100% and a sensitivity of 100% for detection of obstructive coronary artery disease as defined as having greater than a 50% stenosis. This is huge to really have such a safe, effective, and efficient way to rule out significant coronary artery disease as compared to our standard of care invasive angiography, which unfortunately, as we know, in our cirrhotic population is associated with a significantly increased risk of major bleeding, increased risk of transfusion with patients often receiving multiple units of packed red blood cells or fresh frozen plasma, leading to subsequent complications. And then the not insignificant fact that studies have also demonstrated that as compared to age, gender, and BMI matched controls, that there is a 6% rate of complicated pseudoaneurysm as compared to 0% in our cirrhotic population. As such, CCTA is just really a game changer for real significant obstructive coronary artery disease prior to transplant.
Well, thank you so much for that thorough review and discussion. So I would thank again for joining us for another installment of the Clinical Liver Disease video series. And thank you to our readers for joining us. And thank you, Dr. Barnard. On behalf of all of us of the CLD team, I hope you found this interview as interesting and inspiring as I have. For more information about the article, please visit us at www.cldlearning.com. And also don't forget to follow us on Twitter at CLD Learning. Thanks again for watching. Thank you.
Thank you.